Welcome to our first lecture in abnormal psychology. Today we're going to be talking about how we define abnormality and how we study and research it. The Earth's strength is in its diversity. Every organism, every creature, every insect, every material on this Earth has a role, has a function, has a piece in what our world needs to form a complete ecosystem. We may not know what each individual organism contributes, but we can rest assured that if we eliminated that organism or that creature or that type of creature, we would suffer the consequences that are as yet unknown to us. Similarly, our human strength is also in our diversity. Each individual has a part to play, and each characteristic that individuals possess have a role in creating a complete human collective. We may not immediately know what our own contribution is, and we may not be able to see what the role of another might be. And yet, just as every creature on this earth contributes to forming a complete ecosystem, so does every characteristic among humans contribute to forming the completion of the human collective. That everybody has a contribution. How do we define what is normal? At what point is somebody unable to make their contribution? At what point is the efforts of an individual, the behaviors of an individual, the experiences of an individual, or the emotions of an individual inhibiting them from making their contribution and inhibiting the benefit of others? So we'll seek to define here today what is normal and what is abnormal. I have been thinking about what is normal quite a bit, as I recently, over the last semester, read a novel, or actually two novels. The first one was called The Circle by Dan Eggers, and the sequel was called The Every. And the thing that brings this to mind when I consider what is normal is that this is a dystopian novel, meaning that it presents a very disturbed society, and yet that society seems rather close to what we are currently coming to. The character pictured here, this book has been made into a movie, and the character pictured here plays a one of the lead roles in it, who becomes the head of a very large company, a very large tech company, that's seeking to integrate all the technological components of our individual identities and of our entire society and world within one global circle. In light of this, the individuals in this company, which comprise many people, believe in what's called full transparency. That is, there should be no secrets. None of us should have any private space. And to that end, this young woman, May, who eventually becomes the head of the company, agrees to be the first person to wear a camera, a new micro camera discovered by this company that are inexpensive to buy. You can see it on her shirt. The circle is in fact a camera, and she agrees to wear it all day, every day, so that none of her interactions, none of her movements, none of her actions, none of what she sees can be kept from any other person. And this becomes a model for a lot of people in the world. Politicians adopt it, and in the end, individuals adopt it. These cameras are in people's homes, ostensibly for safety, and all over the world. And these are live streaming every single thing that an individual does, says, or how they engage in the world. And I have to ask myself, is this normal? I asked myself this when I was a younger woman, but older than my fellow grad students, and people were posting up on Facebook many things that to me, as an older person, seemed very private. And I asked the younger graduate students, how could they feel comfortable revealing so much of themselves in such a public space? And they said, oh no, on the contrary. If we come across someone who hasn't revealed themselves in this public space, we wonder, what is it they have to hide? So what is normal? is this entire collective of people who has sacrificed their own privacy and their own sense of individuality for the sake of transparency and safety. Is that normal? Or are those who opposed that, who defied it, even at the expense of their own lives in some cases, is that normal? And is normal just a relative state? Would the normal of this behavior of full transparency be in fact normative now, whereas a half century ago, this might have been considered the absolute epitome of insanity? And so these are the types of questions that we're going to consider today and in this lecture. Let's consider these behaviors. Talking to oneself. You're walking in a parking lot on your way to a restaurant and you see a homeless person talking to himself. Is that normal? You're walking through the grocery store mumbling to yourself what was on the grocery list you left at home. Is that normal? Why or why not? Taking risk. Someone is rushing on his bike and just blows through the traffic signals. Somebody rides bikes aimlessly through the streets, seemingly oblivious to traffic signals. In both cases, the behavior is the same. Someone is missing the traffic signals on a bike. Pretty dangerous. Is one of these more abnormal than the other, even though the behaviors are the same? God speaks to me. A person says her dog is telling her to do things, but it's okay because God is talking through the dog. A priest tells his parishioners that God speaks through him. Is one of those more normal than the other? Superstition. A 16-year-old boy playing basketball has to wear his lucky underwear because he believes it will help him win the big game. Or a person must wash his hands 500 times before he can leave his house. So in both cases, we have superstition. Is one normal? Is one not normal? And how would we decide? Well, we're going to revisit these examples in a while, but we'll first consider how we would define these. We look at 6 criteria for defining abnormal behaviors, emotions, or experiences. I'm calling them BEEs, B's in the case of this lecture just to save typing space, but we do think of behaviors, emotions, or experiences as being in the range of normal or not normal. In fact, we could probably add thinking or cognition to this as well. So the first thing we looked at is whether it's maladaptive. Does the B hinder the individual's well-being? We'll talk about each of these. We talk about subjective distress. Subjective just means in the first person. So the person who is having the behavior, emotion, experience, cognition is distressed about it. A violation of social norms. The B causes discomfort and distress to other people. It violates commonly accepted behavioral norms. Dangerous. The B poses harm to self or others. Non-normative. The B is rare, distinctive, and uncommon. Irrational or unpredictable. The B makes no logical sense and has no discernible triggers. So those are the 6 that we might look for determining whether something is abnormal. None of them alone are sufficient to make this decision, however. So the first, maladaptivity. Is the person's behavior counterproductive to their own well-being, or does it fail to allow the person to adapt or fit or gain success in the world they live in? We can think of, by nature, all living beings seek to optimize their own potential and well-being, and this well-being is optimized if a person can function well in one's own environment. And we'll look at this functioning in a moment, what we mean by that. Environments vary across culture, time, age, and demographics, so adaptive behaviors also vary. So let's consider these particular behaviors. This happened recently. Dissent. Would you consider dissent to be maladaptive? Does it contribute to his well-being? This person is now charged with federal crimes for invading the Capitol last week. He's from Arizona, and he holds a belief that the election was stolen and that our democracy is at risk. So he charged into the Capitol, broke in with a mob of other people, and now he's under arrest. How would you decide? On what criteria would you base your decision? Is this adaptive? Is this behavior adaptive to this individual? Is this helping somehow this person survive? Consider isolation. When could this be maladaptive? We are all isolating now because of COVID. Is there a point at which the isolation becomes maladaptive? What is the point? When does it no longer succeed in helping this person's well-being? The second criteria, defining function, first of all, we could call functioning in society has a lot of differences. What you, at whatever age you are, what you need to do to function well in society is going to differ from what you needed to do at an earlier age and from what you'll need to do, say, in old age or in childhood. And it might vary if you move to a different place, and it might vary depending on what society or what demographic you happen to live in. So as long as your behaviors are allowing you to function well where you are, that's considered to be functional behavior. If you can't change that, if you attempt to have behavior that's functional in one setting and then have it work in another setting, that's not functional. That might be problematic. So if you live in a really laissez-faire home and then you join the military and you don't adapt to the military existence, you might be failing to show functional behavior. So it includes things like interacting in your social environment, making a living, maintaining friendships, taking care of your health, tending your basic responsibilities, and so forth. All of those are things that you need to adapt in this day and age in most places. In fact, they might be a comprehensive list of what you need to do in almost any place. And so if you have an impairment for function, well, that's a criterion for most of the disorders you'll see in the Diagnostic and Statistical Manual. So it's considered fairly important in making a diagnosis, and those behaviors will vary by your environment. Okay, so the second criterion we look at is subjective distress. So this is a bit more discerning than just whether it's adaptive. So a person with depression, anxiety, unhappiness might be thought of as having abnormal behavior because their own BEE distresses them. Unfortunately, many people lack awareness of their mental state. So, for example, a person who is depressed might feel that this is the normal state, that this is what they truly are, and that those other times when they didn't feel depressed, those were the abnormal times. So the cloud, the horizon can be dampened when it's colored by a mental illness. The adverse state then becomes integrated by the individual as a stable part of identity, and so it might cause them distress. It might be an unhappy state for them, a distressing state for them, and yet they feel that it's their normal state, so they might not be able to articulate that they feel distressed about it. But we can look at that as does the behavior bother you? If you're having intrusive thoughts, are those intrusive thoughts bothering you? If you're dealing with an obsession, or if you're dealing with some sort of anxiety, are you bothered by that? If you're always going to the doctor because you believe you're sick, are you bothered by it? That's the kind of thing we're looking at. A third criterion is that it violates societal standards. What about behaviors that blatantly defy what is considered acceptable in society today? We can see here in San Francisco, there used to be actually a law that said you could be naked. I mean, it permitted being naked just around town. You know, so what do you think about this? So this guy's just walking down the street naked, and you can see the expressions on onlookers' faces that are taken aback. So is this a violation of societal standards, and would we consider it to be abnormal? And I have another example here that I'm not going to play right now because I'm going to use it later because it's a fairly strong example. But what if you see someone just talking on a street corner? Someone who's on the street corner shouting out religious truths, someone who's protesting on the street corner. Are there variations in what we consider acceptable, and where do we draw this line? How about cultural factors? We can consider that these social norms vary from culture to culture. So let's think of culture as socially transmitted behaviors. So whatever is taught to you, transmitted to you about customs, how a person lives each day, what values are held, what's important, what truths must one adhere to? What technology is available? That's part of culture. Attitudes toward things you like, dislike, feel strongly about. Beliefs. All of those things are part of culture, and cultures differ, and cultures determine social norms. And by that, we just mean what's considered normal. So that's a really, it differs by culture. So they can change over time, by place, by age. When you are getting up in years, it might be quite normal to, sleep several times during the day as an adult. But if you did the same thing at the age of, 30, that might be less normal. So these things vary. They also vary depending on where you are. So in the United States, it would be considered really odd if a stranger smiled at you and you didn't smile back. You might be unsettled. If you smile at someone and they looked right at you and didn't return your smile, you might think, oh, they must be preoccupied or they're up to no good. But the same is not true in Japan. In fact, it would be kind of odd if you smiled at a stranger, because there's a value for showing reserve, restraint, and maintaining privacy. So that would be a very different value, and engaging in the same behavior in a different culture would be interpreted quite differently. Eye contact is a second example. In the United States and many parts of Europe, you want to make eye contact with people because it signifies that you're honest and that you're paying attention. But in Latin America, Asian, and some African cultures, it's considered to be rude, confrontational, aggressive. A child who's being reprimanded would be expected to look down and not to look right at and if they were looking directly at the adult who was reprimanding them, they would be considered inappropriate. The next criterion is statistical infrequency. Is this behavior or attribute well outside the normal range for your cohort and culture? So, so we're looking at just a distribution here. So do most people, is this close to the average of what people do? So an example of this is that it's considered normal to have a bit of baby blues, to have a little bit of depression for a couple weeks after you give birth to a baby. That's normal. When does it become no longer frequent, no longer normal, no longer average? Well, if it persists for a couple months, that's pretty out of the ordinary. And if it's accompanied then by hallucinations, that's even more rare. And so if it's really unusual, then we might begin to be concerned. So we look at how are most people on this dimension. Dangerous. Does this can create a danger to the self or to others? When we think of risks to self, we could include things like self-mutilation, like cutting yourself, that some people do for a variety of reasons. It could be included in that. Threats to health. Drug abuse is a threat to your own health. It's a danger to yourself. Certain drug abuse and self-starvation. What I mean by that are things like anorexia or bulimia, which in essence starve the body of nutrients. And again, that's a threat to the self. And suicide, of course, the biggest threat to the self. We also have behaviors that are considered risks to others. So uncontrolled anger that can become emotionally or physically violent is dangerous. Sexual desires, like pedophilia, that might lead you to violate another person sexually, is a danger to others. Addiction, if you're addicted to something and you need resources to buy more drugs because of that addiction, that would pose a danger to others. Irrational or unpredictable. The BEE makes no logical sense and has no discernible triggers. And a few examples of irrational behavior. You wash your hands so much because you're concerned that your hands are dirty, and so you actually shave off your skin. You do it way too much, so your skin begins to bleed and your skin is raw. Or it's not rational for someone to feel pain in a limb that has been amputated, but it happens. But it's not rational. It doesn't make sense, so maybe this is abnormal. It does make sense if we learn about the brain a bit. But to the outsider, it wouldn't make much sense. There is no limb. How could we feel pain? The third bullet point, ingesting a substance for no other reason than to become ill. You're trying to make yourself ill. There is harm to yourself, and it also seems quite irrational. When we think of unpredictable, we might be considering things like, I worked with a student once who had been in the war and had been in some scary situations and was actually triggered to his whole fear mechanism kicked in response to certain triggers, even small triggers and things that I might not even perceive in the environment. And they created such fear in him that he took to riding around with a gun in his car, which seemed like just exacerbated, certainly a danger to others, and also unpredictable, because he would behave quite normally and all of a sudden he'd be triggered and he'd be in this other world. So that was an unpredictable behavior that probably warranted help. And I gave this example of ingesting salt, ingesting salt to alter one's blood profile so that medical attention will be received. Typically, we use a multi-criteria approach, meaning that we use all of these definitions to determine whether an individual's behavior is abnormal, and we look at how far afield it is. So, for example, if a behavior, experience, or emotion is maladaptive, so it prevents someone from functioning, so much anxiety they can't move. It also breaks a social norm, like they refuse to maybe approach somebody because of that anxiety, and it's statistically infrequent. It's way beyond what most people have. Then psychologists might consider defining this as abnormal. And depression is a good example of this because it's commonly seen as a deviation from normative mental stability. So it's a deviation. It's maladaptive, meaning that people who are depressed don't function well in normal life. And it's common, although it's relatively common as disorders go, it's still statistically infrequent. Most people don't have a major depressive disorder in their lifetime. So in that sense, you can see how it uses this multi-criteria approach. And when we get to our definitions of particular disorders, you will see this played out. So in a live class, it might be nice to reconsider this in light of these standards, these criteria for defining abnormality. And you might think through this. In this first example, you might identify that we would probably feel more concern about the homeless person talking to himself than you running through your grocery list, possibly because it seems irrational in the case of the glossy person, in the homeless person. Possibly it's a violation of social norms, presuming we don't just talk to ourselves in a parking lot for no reason. Probably this person isn't experiencing subjective distress. They might not be aware of that they're doing something unusual. It's certainly maladaptive. It's highly unusual. Taking risks. The person who's late and runs through the traffic circles might be a little different from the person who's just seems unaware of their surroundings and just goes through the traffic signals. And in that case, it might be that it's highly unusual, that it's dangerous, and maladaptive. In this third example, the priest versus who feels that God speaks through him may differ from the person who thinks her dog is God is speaking through her dog, because the priest has set out intentionally his life career to do this. And in this case, it's not unusual for a priest to have this belief. This is common within the subgroup of priests. And so it allows that priest to adapt well to the environment of the priesthood. It doesn't seem to be dangerous, irrational, a violation of social norms, distressing to the priest, or highly unusual. The dog situation is far more unusual. And the superstition, probably there's some subjective distress for person B who has to wash his hands so many times. It's also dangerous to himself a bit if he's going to harm his skin eventually. We could also say that it's maladaptive because this person is really going to take quite a long time to leave his house and may lose sleep, have to get up very early, and so forth. So we could define one of these in each case as abnormal, even if the behavior is similar. So we'll review that in the end. First, we're going to move on and talk about stigma, and then we'll get into the DSM-5 criteria. They have the same criteria with slightly different words. So we do have a problem in that a lot of people don't get the help they need for having a mental disorder because there's a lot of stigma associated with it. Stigma we'll define in a moment, and we begin with stereotypes, which are beliefs about an individual based on notions about the group of people with that label, such as the belief that people with mental illness are violent. Stereotypes lead to prejudice, leads to discrimination. And so by prejudice, we just mean prejudging an individual based on what we believe about the characteristic, about the stereotype. And usually these would have negative evaluations of a group. So there's a schema that people in society have a set of expectations for particular groups of people. And because of those expectations, they may not hire a person who has a mental disorder. They might not rent the apartment to them, or they might not want to date that person, for example, and this is because of these stereotypes. And so that becomes stigma. Stigma is that negative label that's attached to you because of this condition or trait. So because you have mental illness, that would be a stigma based on a diagnosis of mental illness. So it's almost like a stain that you perceive on someone else or on yourself just because of a label that's attached to them. And the label may not hold true. That's a tendency to group people all under one characteristic, even if it's not true of that individual. Now, my segues are awkward in this slideshow. So the Diagnostic and Statistical Manual 5, 2013, this is the current diagnostic guide. We'll be looking at a bit more, quite a bit more in this term and a bit more in the next 2 weeks. But this is the Bible of clinical diagnosis. It means this is the go-to. This book is what has all the criteria that allow an official diagnosis and allow insurance to cover, say, treatment for something. So it's a tome, it's a big thick book, and I've given you a copy on the course website. So in this book, the 4 Ds are used to determine what's abnormal. And officially it's 3 Ds, but most practitioners add 1. These will be similar to what we looked at earlier, which were just general ways of thinking of abnormal. So the official criteria in this book is dysfunction, which is, quote, clinically significant disturbance in an individual's cognition, so thinking, emotion regulation, or the ability to control emotions or to deal with them as they emerge rather than letting them control a person, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. So this is quite a mouthful. So first off, we're looking at something that has to do with thinking, emotion regulation, or behavior. Thought, feel, or behavior. And it has to be representative of or reflect some sort of dysfunction in psychology, so the mind, biology, the brain, or perhaps the body, or developmental processes, meaning something was badly amiss or went wrong physically, emotionally, cognitively, in the environment when a person was growing up. So, causes, psychological, biological, or developmental. Effect, problems in cognition, emotion regulation, or behavior. The second D is distress, when a person experiences a disabling condition in social, occupational, or other important activities. So there is psychological or physical pain, or both at the same time, and I think that I accidentally erased some text here, so this should have reflected that there is, that this disabling condition caused the person enough distress that they aren't functioning well in social, occupational, or other activities. So here we have that functional piece. And then deviance, it's non-normative. We already looked at that one. So those are the 3 kind of broader categories that are used in the DSM. And most practitioners also look at dangerousness because it's not officially one of these Ds, but it's added to the list because clinicians do have a duty to report to law enforcement if an individual threatens harm to self or others. So this cannot be ignored and should not be ignored. So we'll consider these 4 Ds as the way the DSM-5 identifies these. So some more from the DSM. Psychological disorders are conditions characterized by abnormal thoughts, feelings, and behaviors, including these significant disturbances in thoughts, feelings, and behaviors reflecting biological, psychological, or developmental dysfunction, leading to significant distress or disability in one's life, and they don't reflect expected or culturally approved responses to certain events. A psychiatrist is a medical doctor, MD, with additional years of training in psychiatry. So they actually go to med school. So they have that full training. You know, they could be your general practitioner if they wanted to, but instead they specialize in psychiatry, which allows them to diagnose, conduct therapy, and prescribe medication. A clinical psychologist is a PhD, a PsyD, or an EDD. Some people some states allow people with a master's degree to consider themselves psychologists, but typically that's not the case. Typically it's represented by a PhD, and you can think of the degree, the college degree, being PhD or PsyD or EDD, but then they have a clinical license to practice, which is why a clinical psychologist. So my degree, for example, is PhD, but I don't have a clinical license to practice. I did not go through that training. So that's the difference between this PhD that I have, which is a research degree, research-focused degree, and the degree that a clinical person has. So that's a doctorate in therapy. If someone has that clinical licensure, along with their PhD, PsyD, or EDD, they can diagnose and conduct therapy with individuals, but typically they can't prescribe medication. You would find a psychologist working as a team with a psychiatrist who prescribes medication if it's required. A counselor might have an LPC, LMHC, LPCC, LCPC. Generally, licensed practicing counselor is sort of what, or licensed mental health counselor, or licensed clinical counselor. So this is a master's degree, so 2 years after college, but then there are also, to get the full licensure, there's a few years of practice under supervision before you are fully licensed. In some states, you can diagnose with a counseling degree. You can't prescribe medication, so if you were a counselor, you would work in cahoots again with a psychiatrist to prescribe the medication. And a social worker, a little bit broader, they get the counseling. It's a Master of Social Work or a licensed counselor in social work. So they also can conduct therapy and have training in psychology, and also can do general social work of the kind you think about, helping with families. In some states, a licensed clinical social worker can diagnose, but they cannot prescribe medication. So again, they would work in colleague with a psychiatrist if that sort of help is needed. So how common are mental disorders? It's difficult to estimate because of comorbidity, which is the occurrence of 2 or more disorders in one person. And also because the criteria have changed. The DSM-5 has altered some criteria. So just some general terms you should know. We have 4 kind of measures that we can take. Prevalence is a general term. It means what % of the population has a condition. So, you know, in the year 2019, blank % of teens experience depression. Point prevalence is at a specific point in time what proportion were actively experiencing that disorder. The % of the population with a particular disorder on December 31, 2020. Lifetime prevalence means the % of people who have ever had it at any point in their lifetime. And then incidence is the number of new cases that occur over a given period of time. So we might be interested in, say, knowing how many new cases of depression emerged during the pandemic, and that would be the incidence rate. So did the incidence rate increase? So rates during COVID-19, survey rates for depression before and after COVID-19 found that depression in particular was higher in every category during COVID-19 compared with before. So mild 24.6% versus 16.2%, moderate, again, almost 2.5 times as high during COVID, and severe, much higher during COVID. And the higher risk rates of depression during COVID was associated with having lower income, having less than $5,000 in savings, and exposure to more stressors. So this unfairly hit people who didn't have resources much more strongly than those who had resources. And that makes a lot of sense. And you might be knowing already that there is a relationship between race, ethnicity, and income. So there's a higher likelihood that people who are not white will have lower income, but it's a double whammy because in this study, they controlled for race ethnicity. So they sort of statistically neutralized the differences between race and ethnicity before they did this analysis and found that people with low income. So it's sort of a double whammy for people for people who are poor and people who are not white, because it's a double hit. So typically we have differences by race for a variety of reasons. So we can see that 16.3% for Hispanic, 13.9% for Asian, 18.6% for Black, whites adults 19.3%, and 28.3% for AIAN, American Indian Alaska Native. So just some brief comment on that is that the stigma factor may come into play here. So, for example, Asian people would typically be less likely to seek help for a mental health problem, but would seek help for a physical problem. And if they go to a traditional Chinese medicine practice, that is going to be integrated, meaning that the mental state and the physical health are not treated separately. And so there may not be an official diagnosis of a mental health problem, but it may be treated within a physical model. So the rates may be similar, but they're diagnosed differently. In Hispanic adults, there may be some stigma attached to seeking help for mental health, so it might be more likely to be handled within the family. The very high interrelation between poverty and people in American Indian Native American communities and the historical trauma to which they were imposed in fairly recent history in this country contributes to these higher rates among this population. And so we have a double whammy then, because if our populations who are not white are also those populations who tend to have higher rates of poverty and who are more greatly affected by the shutdown, then we have a double whammy for those populations. Three types of stigma. We can talk about public stigma, which is a common societal endorsement of negative stereotypes associated with discrimination. So what that means is, you might not want to tell your future employer that you've been struggling with depression. Or when you're first dating someone, you might not for a while tell them that you have social anxiety. So that is because there is this societal endorsement of these negative stereotypes. You want someone to get to know you, the person, before they know that label that's attached to you. And so in the desire to avoid a label, as we just mentioned, you might not seek care, or you might stop care. You don't want those people to know. You don't want to be the one who's seeing a doctor to get help for a certain problem. And that's because of stigma. And that could lead to bigger consequences than just to you as an individual, because it could lead to things like reduced funding for mental health services in general, so that people no longer have access to these services because there's no funding, and there's still funding for physical health. So that's kind of where we're at, in some ways. We have better service for physical health than for mental health. The second type of stigma is self-stigma, which is this internalization of these negative stereotypes. So if people think that anxiety has certain characteristics, you take those on yourself if you have that anxiety. You internalize them. You prejudge yourself. You feel ashamed of having experienced this. Your self-esteem is lower. You feel less worthy, hopeless. You feel that you can be less effective. And so you try less. And these are borne out in research as a common pattern. But internalizing these negative stereotypes is putting a stigma on yourself and seeing yourself as a less worthy person because you're dealing with this particular condition. And this is called a courtesy stigma, which seems like a bit of an unusual, I think we might think of a better term for it, but that's the stigma affecting people associated with person with a mental disorder. So if your child or your loved one has something going wrong with them, you might feel responsible. You might feel like you're going to be blamed or rejected. And that stigma is the stigma that you feel is attached to you for being related to someone with this condition. And so in that case, you might isolate. You might feel betrayed by your friends in an absence of social support. And so you might deny the mental illness. You might not seek help if it's your child and you're concerned that, say, she has anorexia. Maybe you wouldn't seek help because there's that stigma attached to it. And so this is the third type of stigma that we have to be aware of. So what are the consequences of stigma? Well, a lot of people, around half in some samples, need help for some sort of an emotional mental health issue in the past year, but didn't seek help. And why? Well, likely because of stigma. But there are other reasons too that we'll look at in a moment. So stigma does lead to work-related discrimination, which leads to higher self-stigma and stress, which leads to higher rates of suicide. So if you not only have the depression, but in addition to the depression, you have then the stigma or the cognition that because you're depressed, you're less worthy, that can lead to higher rates of suicide. And if we survey people who in a university, this may decrease the likelihood that you will ever in the future seek help because you don't even want to acknowledge that you're dealing with this. We know that social distance as a result of stigma increases throughout the lifespan. So the longer you have the condition, the more stigmatized or ostracized you become. And so by the time you're older, that means your condition is probably worse. And one change to that is, we'll look in a moment at where these stigmas come from, but if mental illness is portrayed as treatable, we can have better outcomes. So if the main idea that we have about someone, well, let's imagine that someone has a particular disease and we believe the disease is treatable. We attach much more hope to a good outcome than if we believe it's untreatable. And it's the same with how we perceive mental illness. If we believe that people can be helped, then we have a much better outcome for that person than if there's a general belief that that person can't be helped and that is just the way they are. And these are portrayals. There are some other barriers for treatment besides stigma, however. They may have less access to treatment, which doesn't mean just there aren't mental health services available, but also that how do you get there when you're working so many hours? And how do you obtain childcare? And how do you taking the bus and all sorts of things like that. There may be a lack of belief in mental health care. They don't think it would help them. They don't think that's the right way to go. And there are higher rates of people from vulnerable populations who don't believe in mental health treatment. There might be poor quality care. So it might be that people who come from these poorer groups may get not respected, not being involved in their own treatment decisions, not understanding what the diagnosis or treatment is because of maybe a language barrier or not having the privilege of education. There may be this higher level of stigma. So this spiritual, religious, or cultural beliefs might vary, and so there might be inaccurate information. They may be unable to find a care provider who is similar to them, and the care provider does make a difference. So to have a care provider who's not from your culture, that may not be able to serve you very well because you might have a sense that that person doesn't understand you if you're from a group like this. Racism, bias, or discrimination in treatment settings. There is a history of inappropriate treatments. And so people from some minority groups have a lot of distrust of the medical system in general. And that distrust plays out in terms of leading to misdiagnosis or inappropriate treatments. So there's kind of a bad history there. And then, of course, language barriers. So it's difficult to help somebody if there is that language barrier and inadequate representation of that particular group in the mental health professionals. And finally, health insurance. You know, health insurance is a big issue in this country overall, but people from the poorest groups who may be dealing with the most stress and the most reasons to seek care may be also the ones who don't have insurance. Their employer keeps them at just under what they would need to cover them by insurance, or maybe they fall in the middle where they can't get supported help through the state, and so there are a variety of reasons that pay might become an issue. And the reason that these portrayals come to be is, so most of what we know, where do these stereotypes and these stigmas come from? Well, it comes from not usually personal experience. Like many of us, many of you maybe don't know anyone with schizophrenia, or you don't know anyone who's transgender, or anyone who's dealt with severe anxiety. So we're not getting what we know from personal experience, many of us, but from the stories that we get used to. And in most cultures, these stories had at some point come from families or your religious institutions or schools. There were more homogeneous cultures that transmitted values. Now, a lot of cultural attitudes come from mass media. So looking back at some studies from the 80s and 90s, when TV was the dominant form of mass media, TV and movies, characters with mental illness were portrayed as being violent or victimized at 4 to 6 times higher the rate of other characters. In movies, similar, like psychiatric characters that were portrayed were homicidal maniac, narcissistic parasite, seductress, enlightened member of society, rebellious free spirit, and zoo specimen. And so it just means that they're characterizing as many of the characters as harmful to others. And news stories tend to, it does a little bit better, but because news stories tend to focus on isolated incidents like high-profile crimes, the stories can have a focus on when mental illness comes into play with that. So there's not a lot of reason to publicize about a high-functioning person with mental illness. So the only things that we see in the news media are when someone who has a mental illness also engages in something unusual, like some sort of a crime. And so then we come up with that as one example of bad press that just comes as the consequence of the type of news report, and also misuse of terms like not quite understanding what schizophrenia means or psychotic means. Today we have some improvement in that. You know, the movies have a few good, A Beautiful Mind, for example. There are movies that come out with positive portrayals of mental illness. And even more importantly, I think people who have been in the spotlight have the courage to come out and have mental and acknowledge that they've coped with depression or coped with anxiety or something of the sort. And so the more this happens, the more we can get images in our mind that aren't linked to things like homicidal maniac. Now, we do have official recognition of some cultural differences in the DSM-5. I've listed, and I won't read through some of the concepts of distress that are listed in the DSM, but ataque de nervios, I'm not pronouncing that as well as I could, is how it's described in individuals of Latino descent, and it's like an attack of nerves, sort of like we might call it, in lay terms, a nervous breakdown, or it might be some sort of a panic attack or attack of anxiety, so it has a different name there. Ghost sickness is something that Native American people may have a background with in a variety of, in several tribes. And it's a preoccupation described in the DSM-5 as a preoccupation with death and the deceased, including bad dreams, weakness, feelings of danger, loss of appetite, faintness, dizziness, fear, Hallucinations, loss of consciousness, confusion, feelings of futility, and a sense of suffocation are how the DSM-5 describes it, and it's named ghost sickness. And so the DSM is positing that this is a way that within that culture distress would be described. Interpersonal fear disorder in the Japanese culture would be anxieties about an avoidance of interpersonal situations due to thought, feeling, or conviction that your appearance and actions are inadequate or offensive to others, like a heightened concern that your presence, your mere presence, or something that you're doing will offend others. It might be a variant that occurs in the US is concern over an offensive body odor, even if such an odor isn't really present, but a heightened concern about how you're affecting other people. And these all seem to be cultural representations of distress. So here's the question, and the question is this: do prescriptions and therapies cross cultural lines effectively? So what we identify as the cause is how we treat. So if we identify the cause of a disorder as chemical imbalance, then the treatment for that disorder would be chemicals, like a medication. If we believe that the cause of a disorder is poor upbringing, like your parents were too hard on you, or your mother didn't nurse you long enough, or something like that, then the treatment might be psychotherapy, helping you gain insight into the problem so that you can release it and let it go. If the cause of your disorder is that you've just learned a behavior through reinforcers and punishers across your lifetime, and that behavior is now detrimental to you and causing you distress, then the treatment is behavioral therapy, reinforcing and reinforcement for different, alternative, more adaptive behaviors. If the cause is deemed to be negative thought patterns, then the treatment is cognitive therapy, retraining your thought patterns, reshaping your brain. But when we think about culture, what if the cause, as was in is in one of the examples on the previous page, what if the cause is like envy? Someone is envious of you and has kind of done this to you. Or the cause is witchcraft. Or the cause is the loss of one's soul. So do we treat it differently depending on how we view the cause? And what if you're getting treated by someone who doesn't believe in your cause, but you do? Then does the treatment make a difference? So we can't validate what the cause is, but you're experiencing the symptoms and you think the cause is that someone has cursed you, and the doctor doesn't believe in that and treats you believing it's a different cause. Does that make a difference? So this brings us to a question that I'm not going to answer fully in this slideshow, but empirically driven research. So in order to determine treatment effectiveness, how do we know? Is the doctor or are you? We have to conduct studies in which two equal sets of individuals are placed in equivalent conditions, and then, unknown to themselves or the researchers, they receive either the treatment or a placebo. And so in order to determine whether, say, the doctor's interpretation of a patient's depression, and the patient thinks it's caused by, an envious person who has cast a spell on them, and the doctor thinks it's caused by a chemical imbalance, and the doctor decides to treat with medication, we would have to have a sample of people who are all of that belief, of the same belief. That would have to be part of the groups. And so if we get a whole bunch of people like that who are experiencing depression and who believe that it's caused by this, the envy of another person near them, then we treat everyone with a pill, but half the pills have medication and half don't. That's what we're talking about. So we take that whole group of people, we randomly assign one to get a placebo, one to get treatment, the next one to get a placebo, a sugar pill that looks just like the treatment, and we'd randomly assign them. If we randomly assign them, we can expect that they'll be similar. And we have a fake medication that looks just like the real medication. We call it a placebo. And it's a blind design. That means that participants don't know if they receive the medicine or not. And in fact, even better, let's do a double-blind design. Let's make sure that the doctor doesn't also know whether any one individual receives the treatment or placebo, so that the doctor can't put his own mind into what he thinks the results should be. That's the optimal study. That's the only way we can determine cause, that we can determine whether the treatment actually causes the outcome, is by having situations as similar as possible. It looks like this. Here's our population, let's say, of individuals who are depressed and who have a belief about the cause of the depression. We randomly divide them into two groups, and then we intervene. In this case, the intervention that's shown in this example is that they're whether they found a job. Okay, so we have an intervention, and then the success of it is measured by whether they found a job. And then we have the control group with no intervention, and we also look for whether they found a job. And we see that twice as many people found a job in the intervention group as in the control group. So that's the idea. There are other types of studies. We have correlational studies to see if there's a relationship between some intervention and an outcome. Like if we measure sunlight exposure to depression in one group of people, then we can know, that they're related, but we can't know whether sunlight causes depression. We just know that there's a relationship or there's not a relationship. Maybe depression causes people to get out in the sun more, or lack of depression, or maybe, athletic people get out in the sun more and have less depression, but the reason is that they're athletic and they're active. We can do case studies. We can follow individual patients over time, and we can document change in an individual, but we can't generalize that to a population. So whatever the individual experiences, we can't say, therefore, it's likely that the same thing would happen with other people. So really the randomized controlled trial, you'll be reading about it, and that's the best way to go in terms of determining effectiveness. So in summary, we talked about abnormality being determined by whether it's maladaptive, non-normative, distressing to an individual, in violation of social norms, unpredictable, illogical, and dangerous. A multi-dimension approach is most common. The DSM-5 uses 4 Ds, dysfunction, distress, and deviance, supplemented informally by dangerousness. Differences in cultural norms demand care when we're assessing whether a behavior is actually abnormal, as well as when we're treating it. And experimental designs are the only way to determine whether an intervention causes an outcome, such as that a medicine treats a condition. And there we will stop, and I thank you for tuning in.